So, after this presentation, we'll be moving to the scientific part of the meeting. I think we might have some time for question. I ask you to keep the question together, so at the end of each session, we will be having time with other colleagues that have been discussing about potential questions that you might have. So, I have the honor to introduce the discussion, speaking about the disease and the drug treatment for that. I won't be much long on that because also some of colleagues that will be following me will be discussing about some specific details, so I don't want to be redundant. And again, if you need some specific information, there will be time for questions later this morning. So, as you probably know, and you possibly know, Erdheim-Chester disease is an infrequent form of histiocytosis. What is in histiocytosis is a disease in which histiocytes, which are cells of the immune system, do accumulate and infiltrate and enter different tissues and organs. And they have a specific aspect if you look at the microscopy, so pathologists can recognize. Being so infrequent and having many confounder, as you know, it's quite common that the diagnosis is delayed and the disease is not recognized quickly. Those cells have some specific aspect that you can take a look in the microscope and get information about that. But it's difficult because, as you know, clinical finding, symptoms, and manifestation depends deeply on the type of the organ that is affected and by extension and severity of this infiltration. And similarly, the disease is different in different people. In some people it's just minimal with some minor bone pain or something like that. In some people, unfortunately, it's more diffuse and difficult. Indeed, as I told you, we may have indolent form that goes for years without any specific manifestation and more worrying form. And so Erdheim-Chester disease is one of the prototypical diseases in medicine for which is needed a tailored treatment, a tailored care. The care of patient is different from case to case. An experienced physician will be in the need to pick up the best treatment for everyone. I'm quite happy and I have a strong emotion in remembering this work that has been published 4 years ago, but was actually the result of a consensus that we have with many colleagues are here. And this work represents the first guidelines in the world created for diagnosis and managing Erdheim-Chester disease. This work has been made possible only thanks to the action of the Erdheim-Chester Global Alliance, who organized a convene of these scientists and organized us to speak and talk and find an agreement. So I think this is a good occasion for thanking Kathy and all the staff for all she's doing for the care of this patient. That's because actually before this year, the treatment for patients with Erdheim-Chester disease was based mostly on anecdotal report and from treatment that we typically use for other diseases. We have a problem. As you know, the condition is rare. We don't have the typical study that we use in different diseases and conditions to have support, have data support for treating our patient. We don't have trials. And different pharmacological approaches have been developed over time for treating this patient. To try, there's a 3, it should be a 4, but to try to make a summary of what now is typically used for treat these diseases, we can subcategorize treatment in 4 different families. The first one is, let's say also the most historical one, is by using classes of drugs that are called antimetabolites. Those drugs will be killing or impairing the function of some specific immune cells those that are affected by Erdheim-Chester disease, so the histiocyte. And by blocking those cells, you may have a chance for treating the condition or the disease itself. At this very stage, those treatments are less used than other ones if the patient can actually have a good access to the treatment available. The other great category of treatment is interferon. Interferon was one of the major breakthroughs in treatment of Erdheim-Chester disease, actually it dates back to the early 2000s, this paper describing for the first time the usage of interferon. It could be considered the first form of treatment of very mild, or at least milder form of Erdheim-Chester disease, not complicated, and although unfortunately, if the disease progresses and is more extended, the efficacy of this treatment is limited. So my center, there are differences in the word, for example, use interferon in the initial phase when there's no signs of organ involvement and if the patient tolerates it. Interferon is quite a safe drug, but is quite often associated with some side effects. Maybe some of you maybe have used this drug. The typical one is the fact that this drug, interferon, is the drug that our immune system produces when we got an infection, when we got influenza, when we got a viral infection. And indeed, injecting this drug into the body creates more or less the same symptoms that a person has when he got a viral infection. So some degrees of fever, some muscle aches, some bone pain, and something like that. It can create some other side effects that the physician in charge should be in knowledge due to the fact that this drug is able to activate the immune system. In some cases, interferon could create manifestations that interfere with the life with the patient, such as depression or extreme fatigue. And in these cases, we must evaluate if needing to refer the patient for a consultation to a specialist or possibly to change the drug. The second class of drug is the so-called anti-cytokine treatment. Cytokines are small molecules produced by the immune system in order to have the cells of the immune system communicate one to another. So some cells produce those substances to tell other cells to activate, to recruit those cells to inflammation site, and to coordinate an immune response. And when in a disease you have a deranged immune response, like Erdheim-Chester disease, where those cells, those histiocytes, goes to site and infiltrate it without a specific need, those cytokines are clearly a part of the mechanism for which those cells go into the tissue. And if we block those cytokines, you may have a beneficial effect. And indeed, some strategy developed from this center and other centers throughout the world were aiming at blocking those cytokines. Blocking cytokines is not something new, is not something typical just of Erdheim-Chester disease. It's something that is quite frequently used in other diseases like rheumatoid arthritis and other inflammatory conditions. And indeed, many of those products, of those medicines, are mediated from those diseases. The first data were on a molecule called anakinra. Anakinra, its brand name is Kineret, is a drug that was developed for treating rheumatoid arthritis and other conditions later, and it blocked one substance which is called interleukin-1. And it has some effect. We have some good literature suggesting that anakinra could work in a number of patients, and also anakinra is quite a safe drug. And so it may be possible to use that in combination with other treatment to enhance the effect of those treatments on the patient. For example, this is a piece of literature that we have published that showed how interleukin-1 was extremely effective in treating one specific manifestation of Erdheim-Chester disease in a patient who has strong inflammation in the heart that was really placing the life of this patient at risk, and that was stopped by treatment with these substances. It's extremely safe. It just increases a little bit the risk of non-life-threatening upper airways infection. Quite often, patients experience pain in the site of injection, and this drug must be delivered daily. So it may be somehow disturbing in some cases. The other treatments that are available blocking cytokines are the so-called TNF inhibitors. TNF inhibitors are used typically in diseases such, again, rheumatoid arthritis. And one of them, infliximab, is being used typically in Erdheim-Chester disease. The efficacy is variable. The tolerability profile is typically quite good. And there are works suggesting that this treatment may be effective in patients with Erdheim-Chester disease. Another drug that was used also by our center is blocking another substance which is called interleukin-6 at this time. And this drug, the drug that blocked this substance, again used in rheumatoid arthritis, the name of this drug is tocilizumab. The brand name is Actemra or Actemra in the States. And this drug is effective in stopping these substances. We had experiences in using this drug, but what we see is that the drug may be extremely effective in treating the systemic manifestation of the disease. Unfortunately, is not effective in treating the central nervous system localization of the disease, which may be a problem for the disease. And this is possibly due to the fact that this molecule is not able to enter the brain. It's stopped outside in the circulation. So it's working quite well on the external manifestation of the disease, but not of the brain. And this is clearly a limitation for the treatment with this drug. The new great family of drugs that probably you quite well know are the so-called target therapy. Due to the work of scientists and researchers, many of whom are represented and are present here in this room, it has been shown that a significant number of patients with Erdheim-Chester disease have a mutation in one of those molecules. Those molecules are inside our cells and tell the cell that you need to start and be activated to reproduce, to duplicate, and also to activate. The most common mutation, as you probably know, is a mutation in one gene which is called BRAF, and the other mutation in the same group of protein here, activation, have been described in Erdheim-Chester disease as well as in other histiocytosis. When there's a mutation in those proteins, what happens is that this cycle, this cascade, which is normally silent and activated just when needed, is pathologically activated. So the cells is like if you push you push to a maximum an engine. So the cell is constantly and finalistically activated. What does targeted therapy do? By means of small molecules, they interfere with the action of those proteins here, and they stop this pathological activation of the cell. This is extremely interesting, although as it has been discussed and clear, that the mutation is present, for example, the BRAF mutation is present only in a fraction of patients with Erdheim-Chester disease, and also inside of the patient that have a mutated gene, some of the cells are not mutated. So there's a mix-up even in patient who has the mutation of normal cells and mutated cells. Clearly enough, those treatments may not be very effective on the second part, on the non-mutated cell. The idea is that, going back to the scheme that represent the pathological activation in Erdheim-Chester disease, if you block inside the cell those mutations, you will have a blockade of also all the inflammatory pathway that is downstream to this mutation. There are, as I told you, other mutations that have been identified, but luckily enough, all those mutations go to a common point, which is represented by the MEK enzyme. And luckily enough, we may have drugs now to target those proteins, so blocking virtually other mutations that could be involved. And indeed, there are two great families of drugs that are inside this targeted therapy group, which are the so-called BRAF inhibitors, that are the molecules that stop BRAF, and the MEK inhibitors, that are the molecules that stop another molecule, which is called MEK, and this downstream BRAF. So by blocking this molecule, you also block the activation of other genes that may be mutated upstream. Those treatments have been developed for other conditions, but then by means of studies, basket trials, or also observational studies, again conducted by friends and colleagues in this room, they showed that those treatments have significant efficacy on Erdheim-Chester disease. However, we know that those drugs, are associated also with some significant toxicity. And so we have to keep in our mind when we decide to prescribe this drug, and also we need to follow up all the patients that are treated with this drug strictly in order to minimize the side effect. This toxicity is one of the reasons, for example, for which you know that typically we use a lower dose of those drugs in patients with Erdheim-Chester disease with regards of the classical indication. Those drugs are clearly used in patients that have more important manifestation of the disease, or patients that are not responding to the first-line treatment of the disease. And vemurafenib and other drugs targeting BRAF are used in patients who have the mutation in this gene. For the moment, but things will be probably changing in the next years, cobimetinib is used in patients who have no mutation of the BRAF gene or that are not tolerant to the first line of treatment. And these are indeed the doses. As I told you, the doses are typically reduced as compared to the classical doses for the diseases for which they are registered. Those drugs may have significant side effects, as I told you. Some of them are associated with some chemical property of the drug. And so, for example, vemurafenib cannot be used in patients that have some specific problem with electrocardiogram. And indeed, we ask for an electrocardiogram to those patients. We analyze the written and the information about the electrocardiogram. And some patients may not be suitable for taking this drug because there's a risk of problem connected to the electrical impulse into the heart. The typical toxicity of vemurafenib is the skin toxicity. So any one of you who's aware of this drug knows that must be extremely careful for sun exposition, should use strong sun creams, and should have regular dermatological consultation to analyze any change in the skin that should be evaluated. Also, it may have problems with the gastrointestinal tract, and typically there's a worsening of the renal function, a worsening that, however, is not worrying that much. Because if you stop, in some cases it may be worrying, but typically when you stop the drug, the renal function goes back to almost normal level if no problems have occurred. Cobimetinib have many of the same side effects of vemurafenib, One typical is a potentially associated with suffering of the heart, so it should be used with caution in patients that have, for example, heart failure. Again, all this information are unfortunately not originated from patients with Erdheim-Chester disease, but are information that we take from patients with other conditions that have been exposed to this drug. We have data, again generated by people here in this room, that associate the usage of this drug with dramatic and significant clinical and radiological effect in ECD patients. Also, if we have side effects, we should be thinking of using this drug. We should use in a personalized way, and we must follow up patient adequately in order to reduce to a minimum the side effect. There are some tricks that we can use. As I told you, for example, usage of sun creams and sunscreens is important, at least 30 or maybe 50 when you need to be exposed to the sun, regular consultation with the dermatologist, some emollients for the skin that can be extremely dry, some soap substitute or some antibiotic in some cases if you have folliculitis, this for the skin. Gastrointestinal effects are quite frequent, and probably you know that can be managed in many cases just with some minor dietary modification, like eating foods or vegetables that may be associated with a reduction of bowel movement, and so natural reduction of incidence of diarrhea, for example, or the reduction of all those products such as lactose-containing products that are associated with fermentation, and so they can worsen the GI symptoms. A significant number of patients may have some joint pain that should be associated with this treatment, and as you probably know, the usage of low-dose corticosteroids could be helpful for that. Those problems are typically not that major, and sometimes they could be self-limiting, so they do not need a specific treatment. This is significant, and this is the electrophysiological alteration that I told you is a contraindication for treating with vemurafenib, and so a cardiologist and your physician should be taking care of that. In some cases, again, you may have problems with the kidney. In most cases, this goes back, as is shown here. So, for example, this is a patient treated with vemurafenib. You see that this lining going up, showing that the renal function is getting worse. And then when the treatment is stopped, it goes down to normality. So we have to consider that this is the typical way the things goes, although the drug can cause some renal problem. So there should be a follow-up for that. There are other complications that could be there, but again, I'm quite convinced that your physician will be taking care and judge all those things and be advising you for the best treatment. There are some reports, and I'm closing my talk, suggesting that the combination of those drugs, those targeting treatment with other anti-cytokine treatment may be effective and may have multiplicative effects for treating those patients. And there's this nice report, for example, showing the good results of the combination of vemurafenib and anakinra in Erdheim-Chester disease. I just will conclude with a couple of slides with other manifestations of the disease. Many of you may be suffering from them or knowing that. The most common is, for example, diabetes insipidus. Diabetes insipidus is a condition in which the body is not able to keep inside water, and so the patient risks to be dehydrated. The treatment is to use a drug which is called desmopressin. Sorry, this is a typo. Desmopressin, which is given either intranasally as a spray or in tablets. And this is actually the substitute for the substances that is missing. So it's not associated to major side effects, and there's no attenuation of the effect throughout the treatment. There may be pain. Pain is typically managed with painkillers, such as acetaminophen or paracetamol, opioids. Ideally, we should be more cautious in using classical anti-inflammatory drug because we should be aware of kidney problem associated with that, the interference of platelet aggregation, but also we know that anti-inflammatory drug may be associated to a significant cardiovascular effect. Clear enough, we should be also aware of the side effect of the opioids if we use, but if we, again, skillfully and carefully use them, those could be extremely controlled. To conclude my talk, I told you that we are working together for having a consensus, but at this very stage, this consensus is just made by physicians and scientists who treat those patients, and is not universal at this very stage. What is clear to every one of us is that we have to tailor the treatment to each patient. There's no treatment like if you think of pneumonia. If you have pneumonia, you take this drug and then you're healed. The treatment for Erdheim-Chester disease is extremely personalized, as the disease is different in every person that we see. In many cases, interferon-alpha could be the first-line treatment, specifically if the disease is indolent or do not show any specific life-threatening manifestation, and also is one of the drugs that is used in many countries and in many settings in which the access to targeted treatment is more difficult. Life-threatening form require quite often target therapies, such as those, for example, with vemurafenib and cobimetinib we've discussed. They are associated with efficacy in many patients, and in some cases with toxicity. And we can start with those drugs, specifically if the patient had been diagnosed late and already shows some significant manifestation of the disease. Again, I'm shivering at thinking when we first met 10 years ago or so, and we started working on that. At that time, there were no therapeutic options. Now we have a registered drug, we have studies conducting on this disease, and again, thank you for all the things that the Erdheim-Chester Global Alliance has done. And we have dramatically increased the lifespan of this disease that 10 years ago was considered an incurable disease. Not only incurable, but an untreatable, possibly, disease, with a lot of treatment that have just failed. We definitely know, however, to keep on, and the genetic studies that are performed here, the pathophysiology studies that are performed here by colleagues working in different institutions in the world that, again, represented in the room, are needed to even ameliorate the treatment and to target even better the disease in patients with Erdheim-Chester disease. And I thank you very much for your attention, and I would be more than happy to address any question you may have during the discussion in a couple of minutes.